we'll be back later when we can dilate. So trying to do a fundoscopic exam on some of these eyes who are not dilated is really hard. Okay, so how are we going to do it? What do we need in order to do a good ocular ultrasound? First, we need the eye. That's the first step, by the way. Then you're going to get a tegaderm, a generous amount of ultrasound gel. You need a machine, and you use the high-frequency linear probe. Any high-frequency probe will do, but usually for us, that's going to be the linear probe. So how are we going to do it? So what we're going to do is we're going to put the tegaderm on the eye itself. You want to make sure to match it down so there's no air in between the tegaderm and the eye, because air is the enemy of the ultrasound. Then you're going to put a very generous amount of gel, because you want that nice cushion. And then you're going to scan the eye in 2 planes, because you're always going to scan everything in 2 planes. Clear? Does that make sense? All right. So, what are we going to see when we do an ultrasound? Well, here's our eye, right? And you have your kind of your sclera here, and you have your anterior chamber and your lens, and you have your vitreous chamber, and then lining the back of the vitreous chamber, you have your retina, and then you have your optic nerve running through your optic nerve sheath, right? And so when we do an ultrasound, you're going to see pretty much most of these structures, and it's going to look something like this. So you have your anterior chamber here, you have your lens here, you have your vitreous chamber here, and then you have the optic nerve sheath over here, which your optic nerve is running in. Make sense? Clear? So this is what it should look like. And I think the most important thing to remember is that there really should be nothing in here. There should be a black circle. For most of your pathology that you're looking at for the eye, you're going to see something here that shouldn't be here. So it should just be an empty space. So if there's something there that shouldn't be there, you know there's something wrong. All right? So quick, lots of gel. You don't want to push down too hard because it's uncomfortable. Try smashing on your eye for 5 minutes and see how that feels. You also want to limit the amount of time you do an ultrasound because there is energy involved in ultrasound, and the retina is kind of a sensitive area, especially if you're going to Doppler it. So just kind of a point. You don't want to sit there for 20 minutes with the ultrasound probe on the eye. All right. So let's start with the first case. Most of these cases are based on actual cases I saw. So this is somebody who came in. They can't see out of their eye. So they have a few days of vision change in one eye. They see some floaters, some dots. They have worsening vision. There's no pain. So what are we thinking in terms of what's our differential for painless vision loss? Retinal detachment. What else?
2.
Okay, yeah, central retinal artery occlusion. Anything else? Hemorrhage. Good. All right. So we do the ultrasound. This is what we see. So what do you guys see? Right. So remember what I said. There should be nothing in the vitreous chamber here. So what you see here is clearly the retina is coming off. This is a different patient. Similar example.
It did play, sorry.
Oh, what was it? Okay, let's try one thing. Oh, there it is. So by the way, see, first of all, you see how when it moves, it doesn't really kind of shake that much. And also, you see how there's that little kind of cone there? It's kind of connecting it and doesn't really move. So that's a really important point when you're looking at retinal attachment. Have them move their eye and see what happens, because it's sometimes really hard to tell the difference between a retinal attachment and a vitreous hemorrhage. And we have images later on to kind of compare them. You see how it still kind of floats there, despite the moving kind of in the middle, and that's the retinal attachment. And also, a lot of times you'll see like this cone coming down. You see that, you kind of catch it over there, because that's where it's still attached, hopefully over the optic nerve, which is MAC on, which is really important, because MAC on is probably go to the OR within the next day versus MAC off, and they're probably not going to get their vision back. So it's a huge impact on the patient, whether it's MAC on or MAC off, which I'm not expecting you to figure out in the emergency department to make that decision. But this is really going to be really quick to say, okay, this person has a retinal attachment. Let me get on the phone with ophthalmology and say, listen, I have a patient with a retinal attachment right now. All right, so let's move on to the next case. So this is a guy who was in a car accident earlier in the day. The airbags went off. He felt okay. He went home. He didn't even come into the emergency department. But then like hours later in the evening, this happened in the morning, he said, all of a sudden I can't see anything out of my eye. He has no pain, so I do the ultrasound, and this is what I see. So what do you guys see? This is a hemorrhage, right? So you see, first of all, remember, black chambers, there shouldn't be anything in there. But the thing about the vitreous hemorrhage is that it layers out. So even when he moves his eye, you can see the vitreous hemorrhage continuing to layer out through the back of the eye. And that's kind of the giveaway, because a lot of times you have a very difficult time determining the difference between a vitreous hemorrhage and a retinal detachment. Sometimes it's both. So then you're like, oh, I think this is a vitreous hemorrhage, or maybe there's a retinal detachment component, especially in the setting of trauma. You can have both. And so here you can see that it's kind of layering out. It looks kind of different. It doesn't have that cone that you saw with the retinal attachment. It's always not always going to be that clear, but those are kind of the ways you would tell the difference between a vitreous hemorrhage and a retinal attachment. Sense? Good. All right, let's move on to the next one. So this is a guy who's at work. He works in a mechanic shop, and he felt something in his eye, and he has discomfort in his eye. He's got like a foreign body sensation. So this is what his eye looks like. It looks a little bit red. You don't see any obvious foreign bodies. Somebody was sawing next to him, and then he felt something in his eye, and it was kind of uncomfortable. His vision is okay, maybe a little bit blurry, but not really that terrible. And this is all you see. So what are you guys concerned about? Corneal abrasion, good. Foreign body. I mean, you don't see any foreign bodies. You're like, well, what are the chances there's a foreign body? So let's do the ultrasound and see what we find. That's the actual patient's eye. Now, obviously there's something there. Remember, there should be nothing in the vitreous chamber, but it doesn't look like retina. It doesn't look like hemorrhage. It's just kind of sitting there. And you would never know this just based on your exam, right? I mean, it's a little bit injected. He's got a little foreign body sensation. You're like, all right, it's probably just corneal abrasions, and we'll be done with it. And this is the still image. You can see it nicely. And here's the CAT scan of that patient. So he's got a foreign body sitting right in the vitreous, which it's not supposed to be there. And he was okay. He went to the OR later that day, and they were able to remove it successfully. Right, but that actually wasn't in the actual globe. That was like Okay, so the next patient. This is a 35-year-old, 25-year-old girl with no real significant past medical history, who's coming in with 3 weeks of just continuous headache and some blurry vision. Okay? So we do the ultrasound, and what do you guys see? So what are you guys thinking? Like the history is kind of like... What are you guys thinking? Pseudotumor, right? So you guys are concerned that like that's kind of the history like I'm leading you towards. Maybe I say she's a little bit on the bigger side. So what would you expect to see on fundoscopic exam? Papilledema. So could you see that in ultrasound? Well, I'm going to say yes, because I've seen it many times, and this patient had it. And what you see here is, here's the optic nerve sheath, and you see there, right there, there's kind of that bulging, and you're like, I don't know if that's normal or not normal, right? This is why I'm here at this lecture. So let's just compare the eyes, okay? So this is my eye. It's beautiful, I know. And you see here, here's your optic nerve sheath, or my optic nerve sheath, and you see, notice here how it's kind of like flat, right? It's just running along flat here. And here's our patient with their papilledema, and you can see this kind of bulging here, bulging of the disc, and that's exactly what it looks like, right? And it's kind of subtle, but if you look for it, if you look for it in the right clinical scenario, it's pretty obvious, and it's certainly easier to see than fundoscopic. Papilledema, not papilledema. All right. So I'm going to talk to you for a minute about optic nerve sheath diameter. Let me put a corollary around this. I do not believe in doing this in 95% of scenarios. Right? This is kind of stems from it's used to determine elevated intracranial pressure, but the idea being that if you have elevated intracranial pressure, the optic nerve sheath will increase in diameter. So if you measure it, if it's increased, therefore there's elevated intracranial pressure. And my thoughts on this is we have so many better things that are available to us than this, which is I think is kind of very user dependent. you're talking about the difference of 1/10 of a millimeter. If your calculations are, like you can have somebody do it 6 times, and if you say it's 1/10 of a millimeter difference, then you're saying the elevated intracranial pressure versus no elevated intracranial pressure. And we have CAT scans, we can put in invasive devices to really measure these things. So I'm not sure how this would be applicable in our clinical setting pretty much ever. I think if you're in a super resource poor environment and all you have is an ultrasound and a drill, I think therefore there it might be useful to say, okay, let's make a decision on whether or not we need to do some interaction right now. But I don't really do this ever, and I don't really think it has any place in our practice here. But that being said, people like to talk about it, so I'm going to talk about it in this lecture. So the important things to remember for optic nerve sheath diameter is 3 millimeters and 5 millimeters. So what you're going to do is you're going to measure 3 millimeters back into the optic nerve sheath from the back of the retina, and then you're going to measure across, and your cutoff is 5 millimeters. Less than 5 millimeters, normal. Greater than 5 millimeters, maybe there's elevated intracranial pressure. Once again, my eye, I did not have elevated intracranial pressure or any signs of that on the optic nerve sheath. Yeah. I do not have a bleed or anything. I might be big-headed, but it's not. All right, does that make sense? All right. So next is a patient. So I gave this lecture a few years ago at the All-NYC conference, and so I gave this lecture, and then literally I went to a shift at 3 o'clock that day, and I saw this patient. I can't even make this up. It's the same exact day as I gave this lecture, and it was like, man, I wish I had this patient a week earlier. So let's see why it's so interesting. So this is a woman who came in for decreased vision for 5 days. So you put the probe on, you don't see really anything in the vitreous chamber, but I decided to put the Doppler on. Remember, you don't want to do this for too long, but for a little bit. And what you see here is, so here's the optic nerve sheath, and there should be the retinal artery and retinal vein running along there as well, right? And the artery, which would be going in this direction, would be red, and the blue, which is going in this direction away from the eye, the vein, should be blue. So in this case, red is artery and blue is vein. It should be easy to remember. And what do we see here? We see blue. We don't see any red, right? And why would we not see red? So central retinal artery occlusion. So that's exactly what this patient had. And let's see a video of it. So you just see this blue, right? Right there. And you're like, well, I don't know if that's normal or abnormal. So let's take a look at a normal eye. This is the patient's other eye. And you can see here, here's the still image, the red and blue, and you can see here on the video, you can see that artery and venous flow, which is normal. Remember, you don't want to do this for too long, but if you see it, you know you've kind of eliminated the occlusion in the artery vein. Make sense? Should I go back to the abnormal? Just venous flow. And you might need to kind of adjust where you are and kind of to fan just to find the right approach to seeing the artery and the vein. I thought this was pretty cool. Okay, so can we do this? Is there any like data to say that us as emergency physicians should be doing emergency ocular ultrasound in the emergency department? And yes, there's not a ton of data out there. There's not a lot of people doing research on this. Of course, Blivis, who's like kind of the guru of emergency ultrasound. If you think of any emergency ultrasound topic, chances are Blivis did some sort of paper on it in the early 2000s. And so he, of course, has like the biggest article on ocular ultrasound in the emergency department. This is pretty much all the ocular ultrasounds, most of the stuff that I talked about, some of the stuff I didn't talk about. And they basically said that, you know, their results were pretty good in the emergency department. It's not a fantastic study, but it exists. Here's another ultrasound that says that us as emergency physicians are pretty good at detecting retinal detachment on ultrasounds. And then here's another one also on retinal detachment. So there's a couple studies showing retinal detachment. Most of the other stuff is not really there. But I think this isn't really rocket science. And it's not like you're not going to be calling ophthalmology, but it lets you have a better informed conversation with ophthalmology when you get on the phone. First of all, don't forget to get visual acuity, because they're always going to ask it. But another thing you could say is like, listen, I did the ultrasound. Sometimes they might call it a B-scan, because that's what ophthalmologists call it now. And they do ultrasound now as part of their regular practice. They do it in their clinic. A lot of times when you send them over there, they also do that, especially for the retinal say, listen, I see something on the ultrasound. I'm not sure if it's retinal attachment or vitreous hemorrhage. There's definitely something abnormal there, or there's a foreign body in the eye, or I think there's a central retinal vein or artery occlusion. All right. So what are some of the other uses? You can see it as lens displacement and dislocation. So here's an example from that I found online. I haven't really had any good cases in myself. This is from Sonoclab, which so you can see here. Normally the lens is right over here. You can see it sitting there in the middle of the vitreous there. Retrobulbar hemorrhage, you might see that behind the eye. Central retinal vein occlusion, which we kind of discussed a little bit. Retrobulbar abscess, I guess depends on the clinical scenario whether or not you can really determine the difference between an abscess and a hemorrhage. Globe rupture. Now, globe rupture is kind of a relative contraindication doing ultrasound because you don't obviously want to push out an eye that already has a globe rupture. I definitely recommend against using vitreous as your ultrasound gel. It's a big no-no. All right. If you are a little bit concerned about it, you can do a very, very careful ultrasound. Although, well, that's embarrassing. And I would definitely recommend against doing it. But Blindness didn't have any problem doing it. So here you can see, obviously the globe is like severely distorted in shape and size, and most of the fluid is actually out. So you're probably like, hey, what's the worst that can happen? This is from Sono Guide. If you guys don't know about that resource, it's a great resource. It reviews all basic topics of emergency ultrasound. So eyelid pathology, you can actually look to test for just extra ocular movements, like that guy whose eye is completely hematic and swollen shut, and you can't really see in there. You can actually see if have them move his eye back and forth, up and down, or you can even shine a light in the other eye to look for pupillary response. You can actually see that on the ultrasound as well. So there's a lot of stuff we can do with ocular ultrasound, and it's very